Good morning, everyone. So sorry, we're the noisy couple in the back with the little baby, in case you're wondering. I'm Derek Steyn, or Frederik. If you email me through, it'll be f.steyn. And Shu in the back, Dr. Shu No, Associate Professor Shu No, I say, and little baby Hunter. So thank you very much for joining us this morning. I've been invited along mainly to talk about research. Shu and I run a collective research group at the University of Queensland. There's about 15 people in our group. Our group is quite extensive in terms of what we do, and we cover a really broad range of research, all the way from discovering, underlying causes for motor neuron disease, right through to running clinical trials. And so it's a very broad research program, but it's entirely focused on motor neuron disease. Now, I was asked to give an overview of three main topics today. First of all, why do we do MND research? The purpose of the research specifically. What kind of research is available right now here in Queensland? And also then, of course, what are the benefits and also the risks involved in taking part in research? And so what I'm hoping to do is to walk you through all of those points. But before I do that, I just want to kind of come back to something that Rob talked about right at the beginning this morning. And maybe if I include some images in that, I can give you an indication of just how complex MND is from a individual perspective, but also from a research perspective, because this is kind of the reason why there are so many questions that remain unanswered and why we don't have effective treatments and cure for MND at this moment. So when Rob was talking about the neurons in the brain, he was talking about neurons in the small area of the brain, right in the middle, called your motor cortex. The motor cortex is the part in the brain that contains all those neurons that decide on which movements you should make. Okay, now there's a lot of integration there, but effectively those are the neurons that in people with motor neuron disease are affected. Now, unlike dementias or other diseases where the neurons that they are affected is going to impact things like cognition and thinking, these neurons really initiate and control that movement. And that's why when people experience MND, they start to experience very early on changes in movement, but not just movement, also integration. So for a lot of people, the first signs of MND is maybe loss of balance or coordination. And that's a very early sign that those neurons in the brain might in some way be affected. Now, these neurons are quite remarkable in that they run long projections all the way from the brain right down into your spinal cord. So they're very, very long cells. And then in the spinal cord, they connect with another motor neuron. And this motor neuron sends projections out and they physically connect to the muscle. And these two neurons work together to control the muscle. It's those neurons in the spinal cord that are also affected by motor neuron disease. And so if you have motor neuron disease of the brain and the spinal cord, you do have a diagnosis eventually of ALS. And then, of course, there are different subtypes of MND where only the neurons in the brain, or predominantly the neurons in the brain, or predominantly the neurons in the spinal cord are affected. And that's when people are diagnosed with those different subtypes of MND like PLS or PMA. And of course, we know that the outlook and the progression for those individuals are very different for someone with ALS. And so you can see this huge variation just within those two neurons and how it affects the person, and of course how it's going to impact their quality of life, their progression, and of course how we approach those and cures and therapies. Now, it doesn't stop there. Of course, motor neuron disease, we talk about it as a disease of the brain and the spinal cord, but it's also a disease of the muscle. Because once the muscle loses that connection, muscle starts to change. A lot of atrophy can occur, but sometimes, if the neuron is still connected in the spinal cord, but the brain is not connected, that muscle now loses information from the brain, and it becomes tight and stiff. And a lot of people become, very much locked in. They don't lose their muscle, but they lose the ability to use those muscles, and they might experience rigidity, stiffness, and sometimes, just real pain from that muscle cramping as well. And so again, there's another level of complexity there. And then, of course, we now know that, as with most brain diseases, MND can affect other compartments in the brain as well. And so some people might experience slight changes in their cognition and their thinking. Nothing dramatic like we would see in, say, Alzheimer's disease or dementias, but certainly it might change a little bit. On top of that, they might experience changes in their thinking and in their emotions. So a lot of people might experience, unnecessarily elevation and they're laughing, or sometimes more likely to cry at inappropriate times. And it's very, very common, and it's very normal to experience those changes. But of course, it adds to that complexity of what an MND is. And then, of course, once you receive the diagnosis, things like apathy and anxiety can also creep in, and that also changes what happens to the individual with MND. And of course, it can have a big impact on their progression and the way in which they engage with the clinical team, and the way in which that clinical team then can support them and provide, improve the quality of life and survival. And then, of course, there's all those other changes that occur once the muscle becomes affected. So earlier we had a question about lying down, breathing. The same nerves that connect and control our arms and our legs are also those nerves that control the muscles of breathing. And of course, in MND, those muscles become impacted, and it becomes more difficult to breathe when you lie down, because when we're breathing, our rib cage is suddenly going to be impacted by all the stomach contents that's now pushing into the rib cage. And so there's all these other complexities as well that we need to consider. And of course, we know that not everybody experiences the same thing at the same time at the same rate, which means that everybody with MND is effectively different, and their experience with MND is different. And of course, if you want to improve the outcome for that individual, there's just no way that we can accommodate for every single individual difference, because we don't have enough information about everybody and about the disease in order to do so. And so that really kind of sets me up for trying to really give you an indication of just what the spectrum of disease might look like. And so this is a very nice illustration. It's from 2014, so it actually stood the test of time really well. And what it illustrates is what we know as that spectrum of motor neuron disease. And so it's color-coded in a way that can be very confusing, so don't worry about it too much. But on the very far, your left, is a person who's experiencing only lower motor neuron deficits. So when we say lower motor neuron, these are the deficits in the bottom of the spinal cord. And on this side are people who only experience upper motor neuron deficits, so those are those neurons in the brain. And so these individuals are more likely to experience a disease called primary lateral sclerosis. So they don't see a lot of atrophy, they see a lot of rigidity, a lot of cramping, but they don't see the muscles necessarily getting wasted away. Whereas on the very far end, those are the individuals who might lose predominantly motor neurons in their spinal cord. They see a lot of wasting, and quite often it's affecting just maybe their arms or their legs. And then right here we have a disease called ALS. It can either start in the voice box, in the area around the throat, so that's your bulbar onset, affects things like speech and swallowing, or it can affect your limbs, and of course progressive spread there is very different. Now these individuals, because they have both the brain and the spinal cord involved, tend to also have a very different course of disease, slightly more rapid course of disease, and unfortunately the disability can be quite progressive and distressing. So the purpose of research, at least from our perspective, is to really understand all of these factors that can impact that progression of disease. Okay, and this is a big one. You cannot do this by yourselves. There's many researchers that we connect with throughout Australia, but also the rest of the world, that's focused on answering that question. Why is it so variable between individuals? What are the factors that drive progression? What can we do to address those factors? Then, of course, we also want to come up with ways of measuring that variability. And so we do a lot of studies into the biomarkers, what we call that, of heterogeneity. So factors that we can measure either in your blood or in your behaviors. We do studies on activity, for example, that give us an indication of how people are different, and then how we can use that information to either engage with the clinic and provide a better marker for the disease, not just for monitoring progression, but maybe also for earlier diagnosis. We can reduce that diagnostic delay, and how we can then engage with those biomarkers and maybe improve clinical trials. Better ways of measuring disease progression will improve the efficacy and the duration of clinical trials. And then, of course, with all that information engaged, we then move on to what we call clinical trials. And I'll provide a very quick example of how this pathway might work in a research setting. Now, I didn't look at my watch before I started talking, so I have no idea how long I have spoken for. 15. Okay, good. I'm about halfway, so that's really good. So this is an example of how we've structured our lab. So when I say our, I mean the group that Shu and I run. But I want to say that this is dependent, of course, on all of the collaborators and all the different researchers that we work with at the University of Queensland, but across Australia. And what I've got here at the top, as you can see, there's the individual. And that's the person living with motor neuron disease, but it could also be a family member or a friend. We welcome all people into our research because we want to learn from people with MND and then compare that to people who don't have MND. And what we generally do is we make an observation in that individual or in a group of individuals, and we learn from those individuals, and that quite often informs what we do in the lab when it comes to studying models of motor neuron disease. So quite often when I talk about a model of motor neuron disease, we talk about mice. So we do have mouse models that capture a component of the disease. We give these mice motor neuron disease by introducing the genes that cause motor neuron disease. And then we study the impact of that on the animal. And that's how we learn about the mechanisms, the things that affect the neurons, affect the muscles, and then drives understanding of how MND affects the body, which will hopefully translate into further testing and improvement understanding. And that's what we call really those in vivo models. But we also do what's called in vitro modeling. In vitro modeling is a very clever way of taking a single cell and turning it into something that is meaningful in the context of MND. An example is, for a number of years, people in our studies were providing us a bit of skin sample. Shu's group would take those skin cells, they would grow them up in a dish, and then we would reprogram those skin cells to become a human motor neuron. So now we have that person's neuron in a dish, and we can now study that neuron, see how that neuron is defective, and see what we can do to improve the function of those neurons. Now, what's really important is between these in vivo models and those in vitro models, we can then start testing drugs and compounds. And if we improve the disease outcome in the mouse, potentially we can use that treatment for the person. If we can improve the function of that cell in the dish, we can hopefully improve the condition for the person. Combining all that information, we then actually see if it has benefit. And if we do see benefit, then we take that discovery to the next phase, which is where we actually see if it's a safe treatment for people with MND and whether or not it actually has potential to help the individuals with motor neuron disease. And so ultimately the purpose of this is to move into clinical trial. Now, this is a model we proposed maybe 5 or 10 years ago when we first started working with Rob. We've worked really hard to get that into place, and we've only got one example currently of where we went through that entire process and ended up with a clinical trial. And I'll present a little bit of information on that clinical trial for you. But ultimately our goal is to develop something that intervenes, that improves quality of life, slows progression of disease, and one day we hope to develop a cure. And I think that is the purpose of all MND research, is to improve quality of life, slow progression for those currently living with the disease, and then ultimately to provide a cure or prevent it even. So Rob, you'll recognize this photo. So this is an example of how we learn from the individual. That's Rob lying on a bed there. This is 2014 now, Rob. You haven't aged at all since then. So this is basically a person participating in what we call our metabolic studies. At the time, it was very clear that a person's metabolic rate had an impact on their disease. So what we wanted to learn is, what is that impact? And so we set up this research facility, and we had people with MND join us. We went through a series of research tests. I see a few familiar faces in the audience, people who have done this study. So I'll provide a little update on progress on that study today. Anyway, these individuals joined us, and they came for as many visits as they could. It takes a couple of hours in the morning, and we do it every 3 months for as long as people are willing to come back or able to do so. And the first bit of results we published was way back in 2017-18, I think it is now. And what we learned from that was that people who experienced this big change in metabolism unfortunately also had a more severe type of MND that had more rapid progression and unfortunately also increased their risk for earlier death. Now that's a very unfortunate observation, but it clearly indicates an area where we can possibly intervene. And so based on that information, we went back to our animals and we went back to our cells in the lab, and we started looking at potential ways in which we can support the metabolism of those animals and support the metabolism of those cells to see if we can slow down the progression of that disease. And this is really where Shu should be up here today, because she was a big driving force in these studies. Don't worry about all these graphs. I'm not going to go through in detail, but what it demonstrates is that the mouse models of motor neuron disease also went through this big metabolic change, just like the patient. But importantly, there was a drug out there that's currently being used overseas to treat other conditions. And this drug theoretically could impact the metabolism of the cell, specifically the muscle. And so what we decided to do is to give these mice this drug. And when we did that, this drug lowered their metabolic rate. So it brought it back to a normal state, which is quite important because when we then look at the progression and the survival of those animals, so this is what's called the survival graph, and every little bar that you see drop down, unfortunately, is the death of one of those animals. And you can see in the green line, I don't know if it sees that well, but when you give that drug to the animals, not only do you lower their metabolic rate, but you also slow down their progression and you extend that survival. Now, this was enough evidence in combination with the patient data to go to Fight MND and to the university. And through a fair amount of leveraging, we received a grant and we initiated the testing of that drug in people with motor neuron disease. Now, you can't just give a person a drug and expect everything to be good. What you have to do is make sure that that drug is safe. And so this is a safety study. We proposed 3 sites. We proposed Brisbane, Utrecht in the Netherlands, and we also proposed to work with Amar Shalabi in London and England. A couple of things we've learned: don't start a clinical trial before the global pandemic. That's never a good idea. I'll try not to do that again. And also, don't start a clinical trial with the British right before they leave the EU. So a couple of things that kind of slowed us down a little bit. But the 2 research sites here in Brisbane under Rob's guidance and the one in the Netherlands under Leonard's guidance are doing exceptionally well. We've had 18 people now join that study, 18 people almost complete their participation in that safety study, and we haven't had any negative responses to the drug just yet. We only need to include 20 more people, 20 people total in that study to complete the study. And then once we have that, we're going to have a look and see if that drug has had benefit in the individual in terms of changing the metabolism. The study was never weighted to see if it's going to slow the progression of disease. But once we know that the drug is safe, the next step is to leverage for funding and to see if we can run a much bigger study, again in multiple sites, to see if the drug now actually slows down the progression of disease. So I'm thinking you're probably wondering what that study looks like. It's a 12-week treatment regime. It's only 20 weeks in total for the individual involved. On their very first visit, week 0, we have a chat to them. We see if they want to come in and participate in the study. If they would like to, we bring them into our facility. We do a few tests and see if they qualify to participate in the study. We need to make sure the drug is not going to have harm, so we do a lot of questions around the safety of the drug for the individual. We also measure their metabolism, and then if they qualify, we enroll them in the study. We provide them a drug. 4 weeks later, they take the drug home with them. They consume the drug every day. We give them a call, and then we bring them into the research a few weeks later on. They do another measurement, send them home with some more drugs. We give them a call, make sure they take their drugs. And by 16 weeks, we bring them back into the clinic. We do another measurement, make sure that the drug has had no negative effects. We thank them for their participation. And at that point, we let them go home, and we follow up 4 weeks later just to see how they're doing. So you can see it's 20 weeks, relatively easy, simple process when I present it as a slide like this, I guess. But obviously, it does involve traveling to the hospital and doing all those other things. I know of some people in this room who may have participated in that study. I won't tell you who they are, that's confidential, but positive feedback overall. Now, this is generally the concept for an interventional study. Okay, and the reason I'm presenting this to you is because, I think the very first step to participating in research is realizing that it's not as scary as it looks or seems. The problem with research is that when you come and do research, you are flooded with a huge amount of information. And it's this information that can quite often scare the person away from participating in research. Now, our solution has been to enroll people into research early on. Our purpose really is to enroll people into research early on during their diagnosis or following their diagnosis, and to get them involved in just one study. And during that study, they get to learn the researchers, who they are, our eccentricities. Sometimes researchers are funny people to talk to, and We don't always gel, but most of the time people enjoy that experience. And during that research visit, you learn about all the other opportunities out there, and that's where the individual can then choose whether they want to participate in more research and extend their participation in other studies. This slide is not here to overwhelm you. It just gives you an indication of just how many studies are currently running at the University of Queensland. I just described the metabolism study. We have a study that is specifically looking at the slower progressing types of MND, PLS and PMA. That study is called Belong. It's a study looking specifically at how MND is affecting the brain and the spinal cord. Uses some interesting MRI techniques, so brain scanners. We have a new study that's called Track MND starting in January, which is working with a company overseas that's coming up with a new clever biomarker, basically using Apple Watch devices or other devices similar to that to try and replace having to go to the clinic all the time for questionnaires, obviously not for clinical care, but certainly for monitoring progression. We do a lot of work on genetics and understanding the genetics of people with MND. We work very closely with SALSA and the researchers there. They collect blood samples from everybody that participate in our studies, look at the genetics, the complex interaction of genetics with the environment, and how that might impact either onset, progression, and in MND. And of course, we also do a lot of biomarker studies with people like Rob and all the other researchers at UQ. I can't possibly give you an idea of all the research out there in a half an hour talk. So I do encourage you to come and have a chat with me, and I can give you more information if you want to know more of it. It seems like it takes a lot of time, but what we've done as a research collective in Brisbane is we've come together and we've designed all these studies to run together, 2.5 hour session in the morning. You come in, you watch your researchers just run around you. Most of the time they're a bit of a blur. In the background, they're collecting so much information, but for you as the participant, it's really just a casual research visit. You have a chat, you lie down, we put some stuff on you, we take some stuff off you, and 2.5 hours later, you're sitting at a cafe having a cappuccino and a bite to eat. It is meant to be that simple. Okay. So, what does it look like? Well, first of all, if you want to participate in research, you come and see us at a research clinic. We spend an hour with you, give you an idea of what's going to happen. You leave with some information, you can make some informed decisions, and then you decide to come in for a research visit. You may choose to come in for a clinical trial, or you may choose to come in for an observational study. If you do observational studies, so those are ones where we learn about MND, you can do as much as you want to. There's no restriction. If you do a clinical trial, you can only really do one at a time. And in between clinical trials, you kind of have to wait for the effect of the drug to wear off before you start a new one. And that's only because you can't see if a drug is working if you are. So she wants me to say hello. If you're on a drug, you can't be on more than one drug because obviously then we don't know which drug is having the benefit. Okay. Now, if you want to get involved in the interventional studies, you will see Rob. And if you want to get involved with the observational studies, you'll see myself and a few other researchers during that visit. And we make sure that we separate the two very, very well so that you don't get confused about which is which. Now, there should be no cost to you as the individual with research, and there should be minimal to no risk. So I say minimal because some of these studies are looking at the safety of that drug, and of course it always carries a small amount of risk. The benefits are very personal. Most people find that simply engaging with researchers provides hope, but also information. There's a lot of misinformation out there. So talking to the researchers is a great way of just getting information straight from the horse's mouth, so to say, and clarity. And quite often, if we don't know the information, we know who to ask. So it's as simple as coming and talking to a researcher. Hey, I've heard about this drug, Torfacin. Can you tell me more about it? I'm sorry, but I do know the researcher who's actually running that study. I'll get in touch with them and get that information for you. So there are benefits in terms of information. And also, it's good for you. We find that most people who join research teams also engage better with their multidisciplinary care, and there's good evidence to show that if you improve care for the individual with MND, you slow down the progression and you extend good quality of life and survival. So there's other benefits to research that maybe not directly related to research, but certainly carries on from research. Now, I'm not going to tell you to get involved in research, but I am going to suggest that if you want to get involved with research, you can either contact Sue Heggie. She's at the RBWH. Sue is a wonderful person to work with, and she can schedule you for a research clinic. If you don't feel like talking to Sue, maybe you want to approach one of us directly and get us to help mediate that process for you, email myself or Shu. We're at the University of Queensland, and we can pass your information on to Sue and get you started into research. And if you don't want to talk to a researcher or a nurse at all, just reach out to Jane and to Sarah. They're always happy to help guide that process as well. So that's spot on 30 minutes. Yep. I got distracted for a second there, but I'll calm down. Thank you very much. And Sarah, it's back to you.